Hello, everyone, and thank you for joining us in today's presentation, where we're going to be examining unmet needs in a brain injury sample referred to RF. And more specifically, we're going to be looking at cross-ethnic comparisons. My name is Patricia Garcia. I'm a clinical neuropsychologist working at the Rehabilitation Hospital of Indiana, and I am also adjunct clinical assistant professor of PM&R with Indiana University School of Medicine. And with me, I have our student, Ellie.
Yes, hello, I am Ellie Kelleher. I am a current senior at Butler University. I am studying psychology, and I have just decided to study mental health counseling at the University of Dayton next year.
And in addition to being very thankful that Ellie is with me, I want to offer my many thanks and recognize the other co-authors and contributors to this project, our RTOC director, Dr. Devan Parrott, Cori Connor, and Kira Thomas.
So our objectives of this project is to examine the differences in perceived unmet needs in post-acute brain injury patients who are referred to the resource facilitation program. With this, we wanted to investigate the degree of reported needs endorsed by a multi-ethnic sample when initially referred to the program. And additionally, we wanted to analyze any differences of unmet needs across ethnic groups. So the significance of this project is that according to the CDC, each year around 1.5 million Americans sustain a traumatic brain injury, meaning that it's a very prevalent issue. According to the World Health Organization, in the next 5 years, traumatic brain injuries will become the leading cause of disability in the United States. And according to the CDC website, they share that racial and ethnic minority groups, particularly non-Hispanic Blacks and Hispanic patients, are less likely to receive follow-up care and rehabilitation following a TBI compared to non-Hispanic white patients. Hispanics continue to expand in the US, and by 2060, we're expected to have a population of over 111 million Hispanics in the United States alone. So a resource facilitation program is a program designed to help individuals receive services, support, and resources to continue everyday life at school and in work post-brain injury. These programs are funded by the state program known as vocational rehabilitation. These programs are much more inclusive than RF, meaning that VR programs are not only for individuals recovering from an acquired brain injury, and additionally, in order to be considered for vocational rehabilitation material, they must have vocational or academic goals, meaning that they must want to return to school or their occupation. So why is it developed, and what is its purpose? One of the major reasons RF was created was to maximize outcome measures. So for example, we had a study done by some of RHI's researchers, particularly Dr. Trexler and Dr. Parrott in 2010, where they were looking at the efficacy of resource facilitation programs. These are the vocational outcomes. And they found that the rates of unemployment or the rates of employment after TBI were less than 40%. But they also found that 64% of those TBI who received RF returned to work and school as compared to 36% of those who did not. In another study also done by Dr. Trexler and Dr. Parrott in 2016, they found that when examining only return to competitive work and not return to school, 69% of the resource facilitation group was able to return compared with the 50% of the control patients. So why is this a necessary component in rehabilitation? Well, TBI is a chronic issue, and due to this chronicity, oh my goodness, chronicity associated with traumatic brain injury it is important to recognize the evolving nature of rehabilitation needs. So just like it is possible for needs to emerge and change at the same time as the recovery process, it is also possible that perceived needs and services after a brain injury differ across ethnic groups. Existing research shows that an estimated 60% of adults hospitalized with a TBI have expressed at least one need 1 year post injury. So these needs are most often services for cognitive and emotional effects, such as strategies for managing success, handling money and finances, and returning to work, but in addition, also improving problem-solving skills, memory, increasing income, improving job skills several years post-injury.
Now, with all of that being said, and recognizing just how successful RF as a program is in minimizing outcome disparities and really sort of maximizing performance and ensuring that individuals return to normal functioning, particularly as it relates to vocational and academic outcomes, but also inclusive of other mental health needs and other possible sort of psychosocial aspects of care. We were interested in examining if this sample being referred to RF, if they were going to be endorsing certain brain injury needs as a function of ethnicity, and if we were going to see any differences associated with someone being Hispanic or not. So for hypothesis 1, we anticipated that the minoritized group is going to have greater unmet needs than the white non-Hispanic group, while taking other demographic information into account or controlling for those variables. And then for our hypothesis 2, we anticipated that the minoritized group is going to have different unmet needs than white non-Hispanics. We did a retrospective chart review. We had a total sample of 455 subjects. We selected all this data and all these participants between 2018 to 2022. Our inclusion criteria involved someone with a brain injury diagnosis, a vocational goal, and a moderate to severe traumatic brain injury or acquired brain injury as defined as either a stroke, drug overdose, ruptured aneurysm, or tumor resection surgery. In terms of our racial and ethnic groups, we classified them initially as Caucasian, Hispanic, and African American. Our outcome measure was the Unmet Needs and Service Use Instrument. This is an instrument that assesses the needs and services received of brain injury survivors after their injury by asking participants to check needed services as well as services that they received from a list of 27 validated services for brain injury survivors. The final scores on the Sun Tzu cover 3 important scales. Scale 1 is the total services reported as needs. The second scale is the total services received. And the third scale is the total number of unmet needs, which is the result of comparing the response to each identified need to the corresponding response on services received. Each of the 3 scales ranges from 0 to 7, 0 being indicative of no need for services, and 27 indicating needing all services. And we ran a regression models investigating the impact of race and ethnicity when included in this predictive model with other key variables. During the recruitment period, as I mentioned before, we had 455 participants who met inclusion-exclusion criteria and therefore were included in the analysis. Of these 455, 77 were African American. We had 7 that were Hispanics and 371 that were Caucasians. Due to the small number of Hispanic participants, African American subjects were combined with the Hispanic subsample to represent our ethnic minority group, and therefore we created, from the initial classifications, we ended up having a white non-Hispanic group and an ethnic minority group. Significant differences between African Americans and Hispanics were not examined due to the small number of Hispanic patients in our sample. However, comparisons between all key variables and demographics were run between the ethnic groups. Significant differences were found between the two groups in terms of years of education, urbanicity, and private insurance coverage. In this sample, Caucasians had significantly more years of education than the ethnic group. However, both were on average between a high school diploma and an associate's degree. And you can see that here, as far as that indicating the overall significant difference. In terms of both groups, again, they had both high school diploma and associate's degree. Now, urbanicity was also different between the groups, with Caucasians reporting significantly more rural addresses. Our sample indicated that about 40.2% of them indicated living in these areas, in comparison to 25% here for ethnic minorities. And finally, Caucasians were more likely to have private insurance coverage, indicated here by this 33.7% in comparison to the ethnic group. Now, results of the Sun Tzu indicated that the entire sample endorsed, on average, nearly 8 needs when entering RF. Differences between ethnic groups were significant, with the ethnic minority group reporting more needs. On average, when asked about the services utilized, the full sample selected, on average, just over 5 services. No significant differences were actually found when we compared that subscale across groups. However, when we looked at unmet needs, the full sample reported an average of about 5 unmet rehabilitation needs upon entry. Caucasian or white non-Hispanic participants from this group reported about 5 average unmet needs, and the ethnic minority sample reported about 6 unmet needs. The difference between the groups was actually significant, statistically significant. And this is a graph just to showcase the frequency or the higher rate of endorsement of unmet needs when looking at the ethnic samples in comparison to white non-Hispanics. And then again, remember that we ended up combining African American and Hispanic samples. For our hypothesis 1, ethnic minorities will have greater unmet needs than the white non-Hispanic group while taking other key variables into account. A hierarchical multiple regression was run to determine if the addition of race improved the prediction of total unmet needs beyond urbanicity, employment status at time of injury, and presence of insurance coverage alone. You'll see that model 1 only includes those 3 variables, which was statistically significant. But then when we added the variable of race and ethnicity, that actually improved our predictive model by 2%, which you can see indicated here. It went from 0.09 from model 1, excluding that race and ethnicity variable, and then improved 2% of 0.069 in this model. Now, we understand that the explained variance is rather small. It is likely that we have additional interactions, but we truly do not have the power nor the sample that is recommended to explore these interactions any further. Now, for our hypothesis 2, ethnic minorities will have different unmet needs than non-minoritized individuals or white non-Hispanics. Regardless of race and ethnicity, what we found was that 50% of the total sample endorsed the following top 4 needs. They wanted better income, improving job skills, paid employment, and learning strategies for improving their memory. No significant differences were detected across ethnic groups when looking at the highest endorsed items. And so when we looked at the endorsement of each item, results indicated that most items were not significantly different across groups or as a function of ethnicity. However, 3 items did show significant different rates of endorsement across the different groups, increasing independence in housekeeping, participation in sort of like sports, but also engaging in spiritual practices or groups seem to really be important items that our ethnic sample actually endorse. So we do see that in terms of overall items that were endorsed, no significant differences, with the exception of those 3 items that I mentioned last, where we do see that our ethnic group considered as very important, continuing to engage in more social practices or just continuing to stay engaged more broadly with their families and society. Now, in summary, what we found was that ethnicity was, in fact, a predictive factor for greater unmet needs, even after controlling for variables such as insurance, employment status, and urbanicity. This addition improved the predictive model for about 2% for detecting unmet needs in a brain injury sample. Regardless of race and ethnicity, our general sample reported similar needs post-TBI, those being needing to improve income, job skills, obtain paid employment, and improve memory deficits. And finally, the minoritized group did report a higher need for participating across different domains of life. Importantly, as far as engaging in spiritual practices, engaging in sports, and increasing overall engagement with household tasks. Now, results of the previous studies, which we've already talked about initially, looking at unmet needs in our brain injury sample research, have established broad needs that may apply to ethnic groups alike. However, considering that the systemic and individual barriers that we tend to encounter with minoritized groups during the rehabilitation process, it is plausible that these individuals have inherently different needs in comparison to white non-Hispanics. And so it is important to continue considering programs like RF and seeing just the efficacy and just how feasible RF as a program could be, as far as helping mitigate the impact of variables like race and geographic location and insurance status and overall disparities for improving brain injury outcomes for ethnic minorities. As far as future directions, more specific to statistical approaches that we may want to consider moving forward, when we have a greater representation of Hispanics in this RF database, and therefore we have more comparable sample sizes, it would be important to conduct propensity score matching types of analyses that would, of course, require a more equal, a more balanced sample across different ethnic groups, and then matching these individuals not only based off of race and ethnicity, but also other important variables to make them, a more equivalent sample size that also shares similar characteristics for a more robust approach as it relates to analyzing this further.
Absolutely. And that leaves us with some unanswered questions, such as how is RF serving the Hispanic community? And are we even thinking of this patient and ethnic population as a target that we want to serve better? For those ones that we are reaching, how is RF capturing their initial needs pre-treatment, and how does that compare to them after they complete the RF program? And it leaves us with the gap of, with the data we've discussed today here, has shown us that RF is a very successful program. However, it's not offering the same quality to those of the ethnic minorities.
So it would be important for future steps to think about the current mechanisms in place that RF has, and thinking of ways of changing those at a more systemic level, of course, so that RF as a system is actually reaching the ethnic population that it needs to reach for better outcome measures.
Absolutely.
And with that, we will end our presentation, and we thank you again for coming and wanting to hear more about this study.